Hello, everyone. It's very nice to see you. My name is Pamela Collins. I'm coming to you from the United States, where I normally work at Johns Hopkins Bloomberg School of Public Health in the Department of Mental Health. And I'd like to welcome you to our session, Mental Health for All. How can innovation in mental health reduce the treatment gap? So around 30 years ago, Chris Murray, Alan Lopez, and Dean Jamieson and their colleagues showed that mental disorders were leading causes of contributors to the global burden of disease. And this was primarily by virtue of their short-term and long-term disability. Of these many conditions, the many types of mental disorders, they showed that major depression alone was the fourth leading contributor to the global disease burden. And others, like schizophrenia, anxiety disorders, also ranked among the top causes. And this is what put mental disorders and the larger field of mental health on the global public health agenda, at least in recent years. Today we know that these conditions also contribute substantially to mortality, primarily when they co-occur with other conditions like heart disease, stroke, cancer, HIV, COVID. So they're very important, and these conditions occur everywhere, right? So over the subsequent 15 years after these research findings, the field grappled with global and local responses in a world with tremendous disparities in mental health outcomes, disparities in access to mental health care, disparities in resources for mental health research. That's really needed to inform how we do the care in the best ways in particular contexts. And those disparities existed and continue to exist both within countries and between countries. In the first 15 years, we saw new approaches to psychiatric epidemiology that sought to better characterize mental disorders across national borders, across cultural contexts, ethnicities, and gender. But researchers also began to deepen the evidence in countries with a dearth of mental health care providers to show how treatment, both psychological interventions and pharmacological interventions, could be delivered well in the community by non-specialist providers, including lay health workers. And this happened in settings as distinct as Uganda and Chile. Over the past 15 years, guidance and resources that enable countries to equip the healthcare workforce to deliver quality mental health services has grown, thanks to the World Health Organization's Mental Health Gap Action Program and other tools. At the same time, research investments in mental health interventions, especially in low and middle income countries, have grown substantially. And the aim of much of that work over the past 15 years has been to bridge the treatment gap. That means ensuring that people who need care can get access to the care that they need. One of the outcomes of these investments was a robust evidence base that showed that non-mental health specialists could deliver evidence-based interventions. A lot of this work focused on psychological interventions for common mental health conditions, particularly using cognitive behavioral approaches. So this has provided a great opportunity to extend care to many more people to close the treatment gap. And I want to be clear that when we talk about the treatment gap, this is a global challenge. It exists in low, middle, and high-income countries. But I think part of the beauty of this increasing global conversation around mental health is that it has deepened and broadened the conversation about how to meet the needs of mental health in populations all around the world. So this is a time for tremendous optimism regarding the potential for science to deliver new breakthroughs capable of tackling some of the greatest mental health challenges. A session this morning actually talked about AI and how AI can actually inform the complexity of brain health, for example. But we need more discussions about how to sustainably scale interventions that have shown effectiveness in settings around the world. So we're going to talk about that today. This session is going to discuss how innovation can meet the needs of policymakers, how it can deliver in low-resource settings, and be driven by people with lived experience. Our panelists will briefly introduce the extent of the burden of poor mental health, they'll spotlight solutions, and we'll consider what policymakers need from research and innovation to develop and implement effective interventions globally, as well as regionally, as well as nationally. And we'll end by showcasing some case studies of effective as well as promising interventions. So we want to really focus on what action is needed to make the vision of care for all a reality, including centering lived experience in designing effective technical and policy solutions. So we're going to be guided by a few questions. What do policymakers really need from science? What areas of research offer the most hope? And then what's the role of different groups, different communities to help translate this hope into reality that's equitable and that's appropriate for the contexts in which people live? So I'm going to briefly introduce our speakers for today. We're going to have two sets of speakers. Our first three speakers will be, one will join us virtually, Dr. Miranda Wolpert, who is the Director of Mental Health at the Wellcome Trust, Dr. Mohammed Abdulaziz, who is the head of the Division of Disease Control and Prevention at Africa CDC, and he will be followed by Dr. Mark Van Ameren, who's the head of the Mental Health Unit at the World Health Organization in Geneva. So they will start us out, they'll give us the lay of the land from their perspectives, and we'll be followed by three speakers who will talk about some of the work that they're currently implementing in different regions. And our first speaker in the second half will be Roy Dahil, who is the co-founder and lead of #MentalHealthPH. We'll have Dr. Thomas Ward of Avatar Therapy Clinical Research Lead, and who's also a research clinical psychologist. Dr. Ward is based at King's College London, and he'll be joining us remotely. And we'll close with David Capo, who is the co-founder and chief executive of You Belong, which is an intervention in Uganda. So that's our panel. Before we jump in, I want you to take a look at this board. We have posed the question to you, what does innovation in mental health mean? And thank you for these incredible responses. And you can see the biggest words are the ones that are the most frequent responses. So youth stands out, the needs for young people, access, equity, accessibility. I see no stigma in big letters up there. Integration, destigmatization, a shift in power relationships, planetary well-being, novel approaches, drones, being able to speak, protecting the vulnerable, free of costs, accessible, holistic care, community-based care, intervention. So a real diversity, and I think a lot of these issues will be touched on as we move forward. So keep watching the Mentimeter. We're going to have a couple of more questions for you as the session goes on. But I want to turn the floor over right now to Dr. Miranda Wolpert.
Thank you. It's an honor to be here, even if it's only virtually. And I've just been looking at your screen and looking at the interesting things that have been coming out from your perspective. So I head up mental health at Wellcome Trust. For those who don't know the Wellcome, we are a big research funder who try and use science to transform the lives of people across the globe by creating new solutions in relation to health. And mental health is one of our 4 areas that we're particularly focused on. And I guess one of the things I wanted to bring here today to start this session is that I feel over the last year, I was here last year as well, I have seen increasingly evidence for hope and evidence for optimism of where we are with mental health science. And I sometimes feel that I need to help other people understand just how close we are to a tipping point of really new and exciting interventions that are going to transform the lives of hundreds of millions of people worldwide. So I have the great privilege within the Wellcome Trust. My only job is to give out money, and to give out money that will advance that agenda. We have a particular agenda of trying to create a step change in early intervention for anxiety, depression, and psychosis. And my job is to help us give out hundreds of millions of pounds and dollars across the world to advance that agenda. And I guess where I want to start today is to share with you some of what we're seeing that is very exciting, that we think is an example of how things are moving and how the new solutions that are coming are going to also smash the stigma around mental health alongside interventions to address stigma more directly. So just to give you our sort of target, by 2032, we want to see at least one new pharmacological intervention, one new non-pharmacological intervention, and one new digital intervention that are accessible and being used, including in low resource settings, and that are really changing the lives of people. And we're seeing evidence that those things are coming. So in terms of pharmacological opportunities, the first new drug for schizophrenia is likely to be approved by the FDA within the next 12 months. This is the first time we have a drug that targets what are called the negative symptoms. Those are where people have brain fog, they can't think properly, they can't function properly. And this medication can actually change that and change those people's lives. There are also new interventions for psychosis for new mothers and others coming through the pipeline. In terms of non-pharmacological interventions, you're going to hear powerful testimony today about some amazing work in Uganda, where peer support and community integration can change the lives of people and make it possible for people to live fulfilling and meaningful lives. And in terms of digital interventions, again, you're going to hear a great example today of ways that we are using digital technology to help people take back control, to address distressing voices, and to find new solutions. And one of the things I want to also share today is equally important is to think about things we're finding don't work. So this year we published findings from a big trial that had been done by researchers we funded, looking at an intervention in schools using mindfulness training. Now, that's not to say that mindfulness training doesn't work brilliantly for individual people or in individual contexts, and it's been shown to work very well for adults and for children in certain contexts. But as a policy intervention to prevent depression in schools, it did not work in this context. It could have been because people didn't practice. It could have been for a variety of reasons. But we want to help have a robust science that tells people what you should do, but also, if necessary, moves resources to other things when something has been found not to work. And central to all of this is working with people who actually live with the experience of mental health problems, who can help make sure that the generations of the future are fit for the future generation. And I'm really heartened to see people putting youth at the heart, because we know most mental health problems start before the age of 30, often well before the age of 30, often around 14, 15 is when we're first starting to see it, but they've often started earlier. And this younger generation are going to be the innovators. They're going to be the message bearers for the future. And they're also the generation who are going to see these great strides. So without further ado, I'll hand on to the next speaker. Thank you.
Wonderful. Thank you so much. So I'd like to invite Mohammed and Mark to the stage. Okay, then we'll start with you, Mohammed. Go ahead.
Okay.
Yes, you have the floor.
Yeah, thank you, Pamela, and thank you, Miranda, for that excellent presentation. We all know that mental and behavioral problems account for about 7% of global burden of diseases and are the leading contributors to economic costs of non-communicable diseases. The COVID-19 pandemic has had a profound impact on mental health across the world, particularly in Africa. According to WHO, the global prevalence of anxiety and depression increased by 25% in the first year of the pandemic. The increased prevalence of mental health problems coincided with, of course, the disruption to services on the continent, and this worsened the situation where in some instances, in some geographic location or countries, the treatment gap we're talking about is as much as 97% of people needing treatment not getting adequate treatment. So mental health is increasing in importance in Africa. Of course, between 2000 and 2015, the continent's population grew by 49%, while the number of years lost to disability because of mental and substance use increased by 52%. With the growing youthful population and more young people experiencing pressures of making a livelihood, psychological problems on the continent are expected to increase, coupled with the climate change posing an important and growing threat to mental well-being, with increased negative impacts of desertification, competition for resources leading to conflicts, and sometimes important cities at risk of sea level rise. If we talk about desertification in the Lake Chad Basin in Africa, in West Africa and Central Africa, sadly Nigeria, Chad, and Cameroon, it's one of the reasons why that area is having a lot of conflicts because of a scramble for resources, and these are some of the very high risk factors for developing mental health disorders. Why do we need innovations in mental health? There is a need for the continent to produce and apply contextual relevant research for Africa-led mental health priorities, develop innovative and culturally sensitive way of delivering evidence-based care to decrease disability and suffering, increase the health and productivity of people with mental health conditions, and reduce the adverse economic impact on individuals. In Africa CDC, we believe that of utmost importance, as reflected in the continental strategy for intervention in non-communicable diseases, injuries, and mental health launched in 2022. And to also say that the most up-to-date Africa CDC strategy, 2023 to 2025, actually one of the main pillars is Africa CDC response to the high burden diseases like non-communicable diseases, injuries, and mental health. We are seeing an evolution to recognize the importance of mental health in the past few years, with some policy commitment at global, regional, and national levels, and some funding also coming in. But there are still unanswered questions on the practical, sustainable solution to reduce the huge treatment gap. To address these challenges, policymakers need innovation that provide personalized, community-centered, and resource-sustainable solutions, fostering collaborations and regulation while ensuring that these innovations are integrated into existing health systems. Innovations that are technologically driven to address mental health promotion and illness prevention and should be community targeting and person-centered. Technologically driven and culturally acceptable, community-based and person-centered remote virtual supports provided by persons with lived experience, consultations, and training. We can now use this technology to ensure that the quality, we talk about task shifting and task sharing, the quality of this task shifting and task sharing is enhanced using technology. It's one of those things that Africa CDC feel can bring more efficiency into what we're doing at that level. Then the digital system that generates data from service users, linked and persons with lived experience linked to national health management information systems and countrywide, innovation that connect persons with lived experience to resources that can be of help. We sometimes forget people with lived experience and they are suffering. And we need to look for technological innovation that can link them up with help in the community. And importantly, this we know that some population use technology more than the others, even in Africa. Like it's more likely for men to use technology than women, and we should be very careful so that our use of innovation and technology does not disadvantage any of the already disadvantaged populations in the community. So we should always subject this digital and innovative solution to this, what we call equity, to be sure that it will not worsen the equity problems we have in delivering. So policymakers should actively support, advocate for and mobilize resources to create an environment conducive to the implementation of mental health services, recognizing the existing funding gap for adoption and application of innovative mental health solutions. Policymakers must take action to secure the necessary financial support. And we in Africa CDC, we're pushing very hard for sustainable financing by our member states. Thank you.
Thank you so much. Over to you, Mark.
It's really great to sit here with Africa CDC, so it's great. And thanks for Wellcome Trust for organizing this event. Mental health is important. Obviously, I would say that given that I work in mental health. But if I look at what is this month, in September, the most downloaded WHO document of the whole website, it's the Doing What Matters in Times of Stress, a stress management guide. The public is clearly interested in mental health now. That wasn't 10 years ago. What is the third most downloaded publication? It's the World Mental Health Report that came out more than a year ago, but still every month gets many hits. Why is that? Because people such as yourselves are interested in thinking through what could be done to address mental health at a larger scale. Now, the question of this panel that I'm supposed to answer is, what do policymakers need from mental health science and innovation to scale up the problems they are facing, right? So what do policymakers need eventually in interventions that they can implement, right? So how do we get there? So the way I see it is it's like there's a Venn diagram of two circles that sometimes don't meet and sometimes they do meet. One is a circle of innovation, smart NGOs, brilliant academics coming up with really good ideas and developing new innovations. The other circle is the routine government services that are, of course, finite in budget and often have a workforce that is not large enough to deal with the enormous mental health needs we have. We need to get these two circles on top of each other, not fully, but overlapping. And how do we get there? We'll get there if we co-design the programs from the beginning. If the innovation works for a brilliant NGO, it's probably too complex to scale up by routine government. Let me give an example of, again, many examples of things, of course, that haven't worked out well. That's easy, we all know examples. Let me give an example where something that did work out. It's an WHO example because I know that one best. It's from Lebanon, where we worked with the government to do something which is not very unique, setting up an e-mental health program, which does basically online CBT for people with depression. Only we did it with the government from the beginning, so it's in their policy. So then we did trials with the government, nicely published trials. And then the government actually made it available routinely to the population. So right now, wherever you are in Lebanon, and if one is depressed, one can access this intervention, which is an evidence-based intervention that works for depression. Is it enough to solve the problem of depression in Lebanon? Absolutely not, because only a small percent of the population will ever use that intervention. But it is access for everybody. And if you look at earlier the Mentimeter thing, if you put the category of access and accessibility together, that was by far the biggest item. So it's really possible if one co-designs with government or with whomever is going to implement the services from the beginning. And the issue is about genuineness. It's really easy to say we're going to go-design. It's really easy to invite the government to a planning meeting. But it's not so easy to co-design from scratch. And that's where we need to go to. Thank you.
Great. Thank you both. So I think I'm hearing a couple of things from both of you. And one is, Mohammed, you're emphasizing the need for innovation that supports quality services, but also innovation that does not increase inequities in access to care, ensuring that you've got people with lived experience involved in this, that you're meeting those needs directly, and also, importantly, advocating for funding, because that's certainly an important part of sustainable implementation. And Mark, implementable interventions in co-design. So bringing the people that are going to make use of this and hopefully help to sustain it, bringing them to the table from the beginning so that they have a role in helping the research to proceed according to their needs and the needs of other stakeholders. Okay, thank you very much. We're going to, so please stay here. We're going to now move to some case studies, and we'll hear about 3 of them. And I'd like to invite our next panelists to the stage. Come on ahead. And we have Roy Dahil. We have Dr. Thomas Ward, who's going to join us on the screen. Yes. And David Capo, who can make himself comfortable. Now, we have another Mentimeter cue for you so that as you listen to, there should be another one coming up, I think sometime soon, that's going to allow you to comment on the case studies that you hear. Okay, so here you are. What are your main takeaways from the case studies? So listen and give us some feedback. Over to you, Roy.
Thank you so much, Pamela. Slides, please.
Okay, so I think folks can keep responding to Mentimeter, but we're going to need to bring Roy's PowerPoint up in the meanwhile. But we'll come back to the results. We'll give it 1 second. In the meanwhile, any questions for each other while we were waiting for the slides?
Maybe just to add that we need the civil society organizations, we need NGOs, all to pile pressure and work with the government to be able to scale up what we're doing in the area of mental health to bridge this treatment gap. Ultimately, the government needs to work with the innovators and people, the young people, the youth, to draw up practical health system solutions that can be able to bridge this treatment gap, because we do not have the health workforce to bridge it now. So we need to turn, whether we like it or not, to innovations that will also guarantee standards in the delivery of services.
Very good. Well, we're going to hear from a younger person now.
Thank you so much, Pamela, and apologies for that one. All right. Where to get help? There's not a single day that I do not receive messages on our social media pages asking this question. When I co-founded #MentalHealthPH in 2016, our initial goal was for people to know what mental health is and its importance. As the awareness campaign gained some traction, we started receiving a surge of messages asking where to get help, how to get help, and do I need help? Even up to now, we still don't have enough answers to where to get help, especially for messages coming from 4 regions in the Philippines. A recent investment study released by the World Health Organization Mental Health Initiative, Special Initiative, reported that there are only about 5 practicing psychiatrists in the Philippines for every 1 million Filipinos, and 1 practicing psychologist for every 1 million Filipinos. In the same case study, it was reported that there are around 3.6 million people with at least one type of mental, neurological, or substance use disorder. Especially during the pandemic, government crisis hotlines observe a sharp increase in number of calls. These numbers might even be underreported, since many Filipinos don't seek help due to stigma and discrimination associated with mental health conditions. In Mental Health PH, we believe public mental health interventions should be on 3 levels: empowering the individual, changing the stigmatizing and harmful narratives in the society, and reinforcing interventions through policy and partnerships at the system level. There were 3 things we have observed why it's difficult for Filipinos to access mental health. First is they don't know where and how to get help. To address this and empower individuals on seeking help, we developed Kapwa MH, a menu-based chatbot deployed on our social media pages to automate and triage service users who are in need of urgent and emergency professional help. This helps ensuring that people who need help will be guided to the appropriate support 24/7. The pilot version of Kapwa MH was supported by Twitter International and scaled up to Facebook and Instagram. However, due to lack of funding, we had to let go of Twitter and focus our resources to Facebook and Instagram chatbots. But here we learned that for someone who is already struggling and confused how and where to get help, to have signpostings like this gives a lot of clarity and hope what to do. Recognizing the need for people to understand when and how to get help, we developed also self-care kits. This was co-produced by our Department of Health that contains information how to take care of your mental health, how and when to seek help, and where to get help. This information can be accessible online, but can also be printed out for distribution for the communities. The second problem is even if they wanted to seek help, they don't know where are the service providers and if there are any. In low-middle income countries like the Philippines, where most professionals and mental health services are concentrated in one city, existing mental health services in their areas might not be readily known. So we developed a verified, readily available, and user-friendly browser-based mental health directory to help people know the nearest support they can access. We highlighted their services that offers remote consultation, or what we call telemedicine, for people in far-flung areas who are in need of help. Having this directory also helps distribute the demand for services to as much service providers that are currently available. This initiative is happily now partnered with the National Center for Mental Health, a government hospital, to make it more comprehensive and complete. And lastly is stigma and discrimination. Having mental health conditions, many Filipinos, especially young people, don't seek professional help because of fear of being viewed as weak or that their mental health is not real. This can lead to untreated mental health conditions, self-harm behaviors, or worse, suicide. To address this, we launched online campaigns to make mental health discussions and content as consistent and readily available as possible. Our campaign, #UsapTayo on Twitter, has been running since 2017, consistently happening every 10s, 20s, and 30s of the month, or days of the month ending with 0, because that's what we want to happen. 0 the stigma, 0 the discrimination, and 0 the suicide cases. This is happening regardless if there are mental health celebrations or not. Mobile applications to improve Filipinos' mental health and well-being are also being developed, funded by the government. We want to make discussions on mental health and information on how to take care of our mental health be as accessible and literally at the tip of our fingertips. All these initiatives were developed by having people with lived mental health conditions at the front and center. They are part, even leading them, and not just recipients of these technologies. On mental health, this also serves as an invitation to support and be interested with digital technologies, and also on mental health. We can leverage digital technology in the level of self, system, and society, and not only be limited to service provisions. I am not a medical doctor or psychologist. Many here might have the same dilemma I once had on how I can help people's mental health when I'm not a practicing mental health professional. But digital technology innovations to address treatment gap is not only limited to providing professional services. Sometimes it can be as simple as helping people answer the questions, where to get help, how to get help, and do I need help? Simple interventions but with great impact that can change people's lives, that can save people's lives. Maraming salamat and thank you so much.
Thanks so much, Roy. And our next speaker is Dr. Thomas Ward, who'll be joining us virtually.
Thank you very much. Just to start by saying that I'm delighted to be here, honoured to be invited, and it's amazing to follow on from hearing about Roy's incredible work that he's just described. So I'm here representing the Avatar Therapy for Psychosis team. I want you to start by imagining the worst bully that you can think of. And imagine that bully following you around day after day, criticizing, humiliating, and shaming you. That's the experience of living with a distressing voice in psychosis. The challenge for any psychological intervention is how do you bring that deeply personal experience, which by definition is not shared with other people, into your therapy in a powerful and helpful way. In Avatar Therapy, we do this by creating a digital avatar to represent the main voice that the person hears. The person's able to choose how the voice looks and how the voice sounds. And supported by a therapist, they engage in a series of dialogues in which they learn to take back power, control, and rebuild confidence. Here's just a very brief illustrative clip of Avatar Therapy in action. Okay, great. Just remember, the main thing today is just to stand up as confidently as you can. Just tell them that you're not going to put up with this abuse anymore and that you're in control, just like we practiced.
I'm ready to go.
Don't go and see your friends today.
They hate you. They're laughing behind your back.
They invited me. I think I should probably go.
Don't go. You'll just embarrass yourself.
No, sort of, I don't care what you say. They're my friends. I'm going to go anyway.
Hi, Susie. That was really brilliant there. Really showing them that you're calling the shots and you're in control now. Really well done. In 2018, our team completed the first fully powered randomized controlled trial of Avatar Therapy, and we showed significant improvements in voice frequency, severity, and distress. We're just coming to the end of another Wellcome-funded follow-up study where we're looking at therapy optimization and delivery across 8 NHS trusts in England and Scotland. Avatar Therapy is an example of a successful mental health innovation, but challenges still remain. The first is that today Avatar Therapy has only been tested in delivery in high-income countries. This needs to change. The second is that the requirement for therapists to voice the avatars using voice transformation software in real-time dialogue presents a barrier to wider scale implementation. Our new project will tackle both of these challenges. For the first time, we're going to test the feasibility and acceptability of avatar therapy delivery in low and middle income contexts. We're going to establish avatar therapy implementation and training hubs in India and Ethiopia. In parallel, it will initially be UK-based, but which will involve international partners from the start. We're also going to develop a version of avatar therapy in which the dialogues are delivered by an AI-powered conversational agent. More of that later. In terms of our Ethiopian partners, the partners are the Department of Psychiatry at Addis Ababa University and the affiliated CDT Africa. Both bring an impressive track record in mental health research. CDT Africa in particular is at the forefront of the development and evaluation of innovative and complex interventions in the Ethiopian context. This new project aligns with CDT Africa goals to develop equitable partnerships that place African institutes at the cutting edge of mental health innovation. Our Indian partners are the All India Institute of Medical Sciences, and in particular the Department of Psychiatry at AIIMS New Delhi. AIIMS New Delhi is at the forefront of mental health service, public mental health service provision, and sets national standards. A guiding principle of AIIMS is to deliver equity of access to services across the underserved regions of India. And as you've heard already, equity of access is a crucial consideration when we think about mental health innovation. Our work will start with a rigorous 6-month process of cultural adaptation of avatar therapy involving diverse stakeholder engagement. We'll train a core leadership team at each hub, who will then train and supervise a wider cohort of therapists. We'll test the feasibility and acceptability of avatar therapy using mixed methods, where we'll explore the perspectives of people engaging in the therapy and those that are trained to deliver the therapy. The project will end by developing site-specific plans, capacity building and sustainable implementation beyond the project. This project is undoubtedly ambitious, but this ambition will be allied to a commitment to responsible and ethical research innovation. We're committed to equitable partnerships and involving people with lived experience of psychosis at the heart of everything that we do. I just want to finish by giving you a taste of an early prototype of the AI-powered virtual conversational agents that we'll be developing over the course of this trial.
Well, you've let yourself go. Look at you, fat and ugly. No, I'm not. You don't sound very sure about that. I am sure. How many times have you said that? Nothing has changed. Look, just go away. You what? I'm in control. I don't need you anymore. You've listened to me in the past. Not anymore.
I just want to finish by again acknowledging the partners who are involved in this work, and in particular the Mental Health Service User Association of Addis Ababa, who have been instrumental in the development of this project. Thank you very much for listening.
Thank you so much, Tom. Okay, into our final case study, we'll turn it over to David Capo.
Thank you. Good, thank you. What I would like to do today is to present to you some innovations from the Global South that we believe are having an impact, that are working, and that we are offering, in a sense, for further discussion and research to the Global North. One of the huge issues that we're facing, as you know, is 85% plus of people in low-income countries such as Uganda do not have access to evidence-based care. One of the big barriers to that is stigma. The stigma of mental health in Uganda and other low-income countries is huge. The stigma is attached not only to the individual person, but to their family. So most people are kept away from any support other than their traditional healers and faith healers. It's one of the reasons why we're developing collaborative relationships with many traditional healers and faith healers so that we can find ways of working together. But stigma is a huge issue. Another major issue is the very, very fragile health system. The health system has virtually no component within its community structure for mental health support. There is not only a medication supply problem, but a very big issue in terms of the lack of psychosocial support. The third major issue is that very small percentage of people who are receiving some evidence-based care find themselves in the very narrow confines in a health system of being in institutional care. So here is a photo, and you might think it looks like a prison. People lined up for breakfast, for their porridge, but in fact, the only issue that is presenting is a serious mental health condition. The hospital in Uganda, the National Mental Hospital, this week has 1,250 patients. It has a 600-bed capacity. So you have double the bed capacity in the hospital. That's the major national hospital, mental hospital in Uganda, Kenya, Rwanda, other East African countries. It is the same situation. These are the issues we face as we move forward. To address these issues and the treatment gap, innovations are necessary. And innovations, as we see it in You Belong, must be low cost, they must be scalable, and they must be easily integrated into the existing health system. They are three of the major factors we believe are necessary for innovations to be workable. So the Deputy Director of the National Mental Hospital, a psychiatrist, and myself, a social worker, in 2016 we formed an NGO called You Belong Uganda. And our main aim is look at ways in which we can strengthen the health system by embedding mental health services within it, particularly in community-based care. The model we began with was about deinstitutionalization, bringing people out of the National Mental Hospital and focusing on family and community as the basis of good support, but also making sure that we have a range of connections within the community of support and care. Strengthening the health system, though, is our main aim. The first program, this is the first innovation that I'd like to put to you that we believe is working and needs further research, further support, so that it can be scaled up. We developed hospital pre-discharge assessments that are not only biomedical, but also psychosocial. So one of our social workers there is assessing the needs of the person about to be discharged. We then have, for the first time in the system in Ugandan healthcare, with medical healthcare, a home pre-discharge assessment. We actually talk to the family. The family in our model becomes an agent of care, not simply a passive receiver of care. They become an active agent, and their lived experience within the family of caring for a person with serious mental illness is really important in that assessment. Transport in Uganda and other low-income countries is incredibly vital. It's so important. So we provide that transport back home, arrival back home, and then we implement a post-discharge empowerment program. Here we have one of our social workers and our psychiatric nurse talking to the main carer in the family with other family members nearby. That empowerment program is crucial. Our work in You Belong Home has been very much subject to good research. We had a grant at that stage from the UK Medical Research Council in a program called Charisma about qualitative research. It showed that what we do here significantly reduces returns to the hospital, and relapses, when they do occur, can be managed in the family home with face-to-face and phone support. You Belong Home is an innovation that is showing that it can work and start to move the focus in mental health support from hospital care to community-based care. Our second innovation, a very, very important innovation about the lived experience of people with psychosis, called Strengthening Care in collaboration with people with lived experience of psychosis in Uganda, SCAPE-U. Funded by Wellcome, this is a major event in our work. It is really trying to say, how can the lived experience of people with psychosis, people in advanced state of recovery, how can they be engaged as major peer support people for those in the early stages of psychosis? This is a very, very interesting feasibility trial that is now underway. What it is doing is saying people in the advanced stages of recovery of psychosis with their lived experience have an impact at 3 stages. Firstly, at the community stage, they're in the middle. They engage in education of primary health workers, of village health teams to start with. The village health teams in Uganda, in each village, are a voluntary group of people, the first line of the healthcare system. They provide an ability and a role in identifying people in need in their villages and trying to get them into the health centres. This is a very important first step. What we're doing is engaging people with lived experience of psychosis in educating the village health teams. On the right is health centres. They are also involved in the education of primary health workers, using the reflection on their lived experience of psychosis in a very powerful message of education and raising awareness and of understanding of psychosis for primary health workers who mostly up to now have had no education in mental health. And thirdly, the issue of household. The individual person in the early stages of psychosis and their family. This is perhaps the most important part of this research, because it is not only engaging the person in the early stages of recovery, it's also engaging the person with lived experience in the family dynamic, helping the family understand this. This is more complex work. It's requiring a lot of support, supervision, education, engagement. But if this feasibility trial works, and we think it is going to, hopefully it will lead for a fully powered trial where we can really understand and get this right. If it can work, and we think it will involve connecting a major cadre of people into the mental health care system in Uganda. These people in advanced stage of recovery with lived experience of psychosis, we call facilitators. The tool they use is called photo voice. So what they do is take photographs in the community of something that speaks to them of their identity, their journey, their recovery, all their issues with psychosis. On the left, on one of these slides, you'll see it's a training session of the facilitators, and he has a photo of clothes on a clothesline. For him, the washing of the clothes was a big symbol to him of recovery. He used that tool as a way of engaging in a participation and a narrative with people about his recovery. Other facilitators have used a motorcycle. In Uganda, we call them boda bodas. the taxi motorcycle. And he used a photo of that to show, well, it's got many parts. Sometimes some parts break down. Some parts are going okay. I need help. I need to go to the doctors, the hospital, the health centre, where the motorbike goes to the repair shop, so I need to go. So they use these photographs, these narratives, to really engage people. This is a major breakthrough in the power of lived experience of psychosis becoming an active role in the healthcare system. It's a powerful model, a model that we think is going to be transformative in the health system in Uganda. As part of this trial, the senior person in mental health in the Ministry of Health is actively involved in this trial. That gives us buy-in to the Ministry of Health. It gives us buy-in to impact of people with lived experience of psychosis in policy development in government. That is a huge step in the right direction. The third innovation that I want to mention involves our youth consultation groups. Every few months, we get together young people with serious mental illness or at the early stages of mental health issues. We get them together and we talk to them, we listen to them. We involve them in our planning of our work and of our programs. We learn so much. One of the most important things we learnt in the last 6 months or so in post-COVID is the massive impact on school children post-COVID infection. The problem with it, it led to massive social isolation of children, massive emotional problems, mental health problems that are now appearing more and more as these children go back to school. We learnt so much about that from these youth consultation groups. We were able to re-gear our programs so that we now have impact in the schools, particularly around teaching teachers, educating teachers. We find teachers in many of the schools are the main problem in the lack of support of children with behavioural issues, mental health issues. Because of teachers' lack of knowledge of mental health issues, mental health conditions are simply seen as behavioural problems and dealt with by corporal punishment, by shaming, by expulsion. In closing, let me say, and this is another photograph from our youth consultation groups, the life, the energy in it. Lived experience of involvement is crucial, but it must never be seen as an issue of utility. It's got to be always seen as an issue of right, the human right of people with lived experience of psychosis, of mental illness, to be at the heart of research, policy development, and program delivery. Thank you very much.
Thank you so much. Thank you to our 3 presenters. And we have a little bit of time for questions in the panel of each other, but I want to start with this last group, ask each of you a question and then give you a chance to reflect. Roy, I loved what you said about a simple intervention, a simple, straightforward intervention that helps people to identify, understand where they can get help, whether they need help, and then help to link them. Yeah. Where would you want to see this go further? Would you want to see it go further? Is there a next step?
Yeah, I think more on the directory, what we wanted to do is that to get as many, not only mental health services, but also other services that might affect or might also complement taking care of our mental health. Currently, what we're inputting in our website directory, it's all mental health services, facilities, those things. But other determinants of health are also important and could be also helpful for persons with mental health conditions. So we also want to explore like what are other initiatives or like support systems that are available there and that could potentially help us and probably map the entire Philippines that and emphasize that help is here and help can be accessible wherever you are in the Philippines.
Great, thank you. Question? Do you have a question, Mark?
I have lots of
Okay.
questions, but I will let him speak.
So I'm gonna then, let me quickly ask Tom a question. Tom, that was, the avatar is a really, really interesting intervention that you're allowing people to practice responding to voices. I'm gonna look at you up here or up here. People are getting to practice, right? How they would respond to a voice that they may be hearing and kind of master that response. Can you tell us a little bit about what co-design looks like and how you're envisioning that as you go to different cultural contexts?
Yeah, exactly. I mean, that's a very good point, Pamela. What I would say here is that we're at the beginning of this project, and really what co-design is going to look like is going to be developed, led by each site. So it's important to acknowledge that it's not going to be sort of me as the lead in the UK deciding, thinking about what co-design will look like at the different sites. But it's important that also to understand that this is not an avatar therapy that's in its final form. We're not going to take this over to India and Ethiopia and expect it not to change. We're actually expecting to learn quite a lot about how people understand voice hearing from different perspectives, different cultural, religious perspectives. And we're looking at a lot of reciprocal learning happening between all of the sites. So I think in terms of what co-design is going to look like, we have an established organisation in Ethiopia. We're going to be very much leading the stakeholder engagement, which is going to include a very diverse engagement of people with psychosis, carers, all across the different sectors of society. They're going to be leading that work in terms of engagement. In India, we're going to be developing models that are going to build on some of the work they've already done in digital health and engagement with service users with people with lived experience. So the plans are still being developed, and how they operate in practice is going to be led by each site.
Okay, thank you. And finally, David, I think you gave us a really comprehensive view of what you're doing in Uganda. And I also wanted to give you a chance to explain kind of how the overall organization works, because you explained to us actually that you're working quite closely with the leadership of Budabika, of the main national hospital. Can you just give the audience a sense of how you're nesting this within the larger mental health system?
Good, thank you. I think one of the very important things we've learnt is that as an NGO that we are, it's very important not to simply see yourselves as a standalone organisation. You can do very good work as a standalone organisation, but you're not going to have a lot of impact to change policy, to change perspectives and attitudes, particularly with government, as a standalone group. So it's the interconnections that have become very, very important. And the mindset that we've developed in our work is primarily we're there to build a system that will provide support within the community for people close to where they live. It's important then, the National Mental Hospital, as it's called, Budabika, is the hospital that absorbs, I suppose, 90% of the funding in mental health in the country. It has lots of resources, but is overcrowded and has no control, really, of the number of people who will be dumped into the hospital every day by police or family or whatever. But working with that hospital is crucial, working together. So the dynamic of working with that hospital, with an MOU that we have with that hospital, means that we are connecting to the main body of care and trying to help refocus the model of care within the hospital to extend to the community as well. Our contact with people in the ministry means that they know that they have our support. We're working with them to produce the best possible model of mental health care in the country. They know that we are a resource for them. So those sorts of trusting relationships we find very, very important. Trust is crucial to get a shift in policy. They're the sorts of things we're trying to do.
Great. Thank you so much. So I want to just acknowledge our panel once more and to thank you for your presentations. But I want to open the floor for questions from our audience. And we'll have a little bit of time for discussion with the audience, and then we'll come back to the panel for some closing remarks and some takeaway points. So the floor is open. You can find a microphone right there in the center. If people can just line up behind the microphones in the center, then we'll take questions that way. There's one in the front here and then one at the back of the room. There you go. Thank you. Okay. Okay, please go ahead.
Hi, I'm Inish. I'm speaking on behalf of the International Federation of Medical Students Associations. And our question is regarding the following. Mental health, due to its particularities and the frequency and continuity of care usually needed, is a big financial burden and not accessible to all people except for some specific projects happening in some countries. What measures do you think should be implemented to make it financially accessible for all?
Great. So, how do we make mental health care financially accessible for all? Who wants to start? I'm looking at Mark and then Mohammed.
Well, the easy answer says make it part of UHC and integrate in primary healthcare. That's the easy answer. But how to get there? And since you are coming from an organization that, medical students organization, I would say the number one step is to get the schools that train medical students and nurses to integrate good training in mental health and in medicine and doctoring and nursing. And we look forward to working with you on that, because that's, I think, is exactly what step one that's needed amongst a number of other steps.
Yeah, thank you, Mark. One thing that is clear, especially in the African continent, is that we need to go even to the level of the community and the use of community health workers. We need to understand that we cannot deliver mental health services using specialists. We have to use the non-specialists in the community and train them to be able to deliver services. And we have some very good tools that have been shown, evidence the WHO image gap. We can support that and ensure that the quality of the services given at that level is assured through innovations like what we've just been discussing. Thank you.
Thank you both. I love that, because I actually think that that's one of the really important utilities of your project, Roy, is that often when people don't think there is access, there are people there. There are people in their communities that people often don't know about. So maybe even and I know there's a new organization that's doing that kind of work, that's actually mapping resources in Africa. So I think making clear what is available and then figuring out where do you need to fill the gaps is an important piece. Before the next person at the mic goes, we have a speaker over here who's going to ask a question.
Good, thank you very much, and good afternoon to everyone. My name is Joseph Baraza from Kenya, LVCT Health. I'm a disability officer there. I've seen the discussions that were involved, the innovations as well. They are very nice. I'd just like to make a recommendation, kindly, in your, like the avatars that you've put on the screen. It will be nice to have sign language in there for deaf individuals, because we do know that you do not leave anyone behind in such innovations.
Thank you very much. A really important contribution. Thank you. Let's go to the back, Mike.
All right. Good afternoon, everyone. I am David Duncan from Special Olympics Jamaica. I'm a person with an intellectual disability, and I'm an athlete leader for Special Olympics and a health messenger. My question is, with all the innovations being made in mental health technologies, how accessible are they to persons in lower income countries, like, for example, the Caribbean? As I'm a person with an intellectual disability, and a lot of this research is new to me. So I'd like to know how easy can persons in the Caribbean get access to this technology, and how educated are they with the understanding and using it? Thank you.
Thank you very much. So for people with intellectual disabilities, number one, are these new technologies keep taking this access in mind? And how globally available are our new digital technologies?
And let me say, the caution it's really clear. And as we move forward to use digital technologies and innovations, we must check them for equity. That this is available. We're not using those technology to further disenfranchise some certain already vulnerable population or population that are already having problem with equity. People with disability, women, and other vulnerable population. We must make sure we are looking and ensuring that the innovations we are using can get to them equally, and the effect it's going to have on the service delivery or other form of risk assessment on them. Thank you.
And I also like to re-echo what Mohammed said on that digitalization can actually really democratize healthcare system, especially mental health care, but it can also exclude. So we have to make sure that whenever we move to these kinds of innovations, we have to make sure that what we're doing, it's inclusive, it's effective, it's ethical, and it's most especially it's safe.
Great, thank you. And I think we may not have specifically answered your question about what's accessible in the Caribbean, but I'm going to leave that as an open question in this room. And if there is somebody that has that information, please raise your hand and let us know before we leave. What I'm going to do now is come back to the first microphone, and we'll alternate, but I'm going to just take about 4 questions, and then we'll let the panel answer, then we'll take another set of questions. So please go ahead.
Yes, hello. Good afternoon. My name is Ute Merker. I'm from IBB Ventures, and I wanted to ask the audience and the panel if you know about the German system of DIGAS, which was introduced end of 2019, which is a reimbursement scheme for apps to support which can be prescribed by a doctor and then used from the patient, and that there are already 25 apps available here in Germany for mental health issues, focusing mainly on depression, panic, and anxiety, which has exploded after the pandemic, like you have shown in your presentation as well. And these are basically digital therapeutics, which have to conduct a controlled randomized trial and show the evidence. And then they will be finally reimbursed. And I wanted to ask you if you know about these kind of schemes in your countries where you are at.
Okay, thank you. And we'll go to the rear microphone.
Yeah. Hello, I thank you very much for this interesting panel. I thought the whole range was covered. I very much liked what Roy has been doing. It's really the preparedness, the pre-feasibility. It's what I call the first step, not the last mile, but the first step. So I encourage and I hope we can work together one day. But I really wanted to ask something to Thomas Ward. I was absolutely scarified. I could never tolerate to see such a face and such a voice. I mean, how can you impose this upon psychotic patients unless you want to have a modern type of shock therapy, electric shock therapy? I mean, really. And the other, what I like very much is for the community approach, where we have the absolute opposite. We go back to gentleness and trust. And for me, really, what I know of, let's say, people with disorders of this kind, and we all have them at times, some more, some less, and sometimes for longer, for less. So let's not think we are out of the risk. But it's a lack of trust. You suddenly feel everything is threatening. So I cannot see the use of a threatening voice, a really threatening. I mean, this is what is my nightmare, what you showed. So I'm very much appreciative of the community approach and the trusting approach, but maybe Thomas can also create a voice and an avatar that are more trust-inspiring. I don't know, because I was really worried about where we go. Are we going into social engineering? Are we also going to take everybody? It's normal that people are depressed according to norms if you are in a welfare state when they live under hardship. So let us not move up the level of what we expect as if people are happy all the time. I don't think this is possible. Look at pictures of people in previous centuries. They always looked a little bit because that was normal. It was you had a different idea of happiness and what life was for. So I would like us to be careful about going further and further into personalizing these things, whereas there's also a societal thing, like this epidemic that people got so socially and psychologically depressed. I have been in Congo in a real lockdown. We were in a cholera epidemic and we were not allowed to move out of that area. There was no healthcare there. There was just absolutely nothing. No electricity, no water. You're not allowed to get out. That, I mean, that is indeed can be traumatic. It was not, because I was young and you just, live it. That's all. But I wonder about that part. If we have to accept a deteriorating environment in a mental sense and also practical sense, and then go with personal solutions. And this question of the avatars and the scary things that you developed. Thank you.
Thank you. Okay, Sylvan.
Hi, my name is Sylvan Ruthenberg. I'm the global lead of the Institute of Neurodiversity, ION. We are a global membership organization representing neurominorities fighting for equal rights and opportunities. And the simple question is, what about neuroaffirmative care? Just to maybe throw you some bullet points, talking about the medical model towards the social model of disability. I've heard a lot about lived experience. I'm also interested about novel therapies, particularly, for instance, for non-speaking neurominorities, which require a very different approach. Thank you.
Thank you. So we're going to do some lightning answers. So if folks want to choose one of the questions to respond to, we'll go around and do that. And I want to start with the German system of reimbursement for these array of apps that have been prescribed by doctors. Is anyone familiar with that in a country where you work, or?
I'm not familiar with the reimbursement part, but the whole idea of an digital intervention being part of the general package is definitely a discussion in many countries. I think actually in the UK in the IAPT. But for example, in Australia, there's places where if you go to the doctor and you say and you're identified as depressed, that there's a choice between an antidepressant or a prescription pad with login details for an online CBT program. The effect size of those are the same as for antidepressants. So the integration into routine care of digital interventions is happening. in settings, and that's good.
Yeah, I think to our colleague from the Caribbean, I think the challenge is what's accessible free of charge. There are some websites that you can access that are free of charge that can do interventions, but you kind of have to look for those. And a lot of other things are not necessarily free of charge.
That's the issue.
I want to come to Tom quickly. So Tom, we're not really clear on whether what we heard was because of the sound over distance, but it was a little intimidating, the sound of the avatar. So can you comment on that? And actually it'd be interesting to hear about the co-design method in the UK that led to the selection of the voice and the face and so on. If you just briefly.
Yeah, thank you so much, and thank you for the question. So firstly, just to start about, I completely agree with the idea that community-focused interventions are crucial in the discussion that we're having. But I think there is a danger if we're telling people that hear distressing voices that we're not willing to listen and think about the reality, the lived reality of their experiences. The lived reality of a distressing voice is frightening. It is scary. It includes content that's actually often social taboos. So a fundamental principle in avatar therapy is that we don't turn away from the reality of the person's experience. We join together with that person and ask questions that they perhaps have never heard before. We ask them, what does that voice say? How does it treat you? How does this, what words and phrases does it use against you? We consider whether that experience is linked to other experiences of marginalization, stigmatization, and discrimination. The person creates their avatar. The co-design process of the avatar is really just the person designs their avatar to match the voice they hear. And the avatar is voiced using the content that the person has shared with you. So I think what we need to remember here is that people often think about people with mental health problems through a lens of fragility. And what we really see are people who are resilient and dealing with experiences that I freely admit are scary on a day-by-day basis. So what we're trying to do with the avatars is have those people develop a sense of feeling less scared, more empowered, more connected with their identity through the course of a series of dialogues. And the other thing I would just briefly say is that the clip, and I apologize for the lack of accessibility of that clip, it was a role play of about 20 or 30 seconds in what is a series of dialogues that occurs over 8 to 10 dialogues. So it's a kind of a snippet of a feel for what the interaction involves, and the dialogue transitions and evolves over time. So I hope that's given people a little bit more of a sense of the intervention.
Thank you. That's incredibly helpful. So just ensuring everyone understood that is that the person who's experiencing the voices is designing the avatar and is actually selecting the voice for the words that they're hearing. So that's and I appreciate that. That's very helpful, I think, to remind people that the experience can be quite frightening. And so you're essentially helping to create that same experience that the person is having. The next question was about neuroaffirmative care. Have folks thought about neuroaffirmative care and what that can look like in the health system? And taking into account neurodiversity in our population.
Yeah, on my end, I have no experience yet on the neuroaffirmative care, but I think I'd like to also comment on these kinds of services, and then also what Mr. mentioned about the different inclusivity. It's also important to have that included in the website, the different layers that we have to consider in terms of access. Are there queer sensitive? Are there for persons who live with HIV, for example? We have to also document that. And I hope to take this opportunity as well to talk to people in the Google or something. Maybe we can develop this map and integrate it to the Google Maps so that it's much easier for users to locate where are the nearest health facilities that is inclusive, that is also positive, and all those kinds of layers.
Thank you. And I suspect, in fact, I'm quite sure that our health systems actually need more training around what neuroaffirmative care actually looks like, and that this is an area that certainly is one for education. So we're down to the last 5 minutes, and I think hopefully you can speak with some of the speakers after the session. But I want to give everyone on the panel a chance to give the audience a takeaway. What is the one in 4 minutes? What's your main message? that you'd like people to live. And we'll go along the row, and then we'll end with Tom on the screen.
Yeah, the main message I would like to leave is that we have no choice. We have to go with innovative ways to bridge the treatment gap that we have currently in the area of mental health. And we just need to ensure that we monitor the how it affects everyone in an equitable way. And let me say, as my last word here, that whatever we do as NGOs program, we should link up with the government so that the government has, if learning from everybody can scale it at scale to increase access. And what I'm saying in one word is that we should work very closely with the government to be able to scale up exactly what we're doing in the countries. Thank you.
Thank you, Mohammed.
Yes, I think there's two themes running through this. One is co-design with people with lived experience. Another one is co-design with people who are going to implement the intervention at scale. So I think that too often, and even when I spoke, we very much focus on one of the two. And likely, if we want to be successful, we're going to have to walk both paths. So co-design with government and with people with experience.
Okay, perfect. Brief.
So I hope with our presence here, and especially in the World Health Summit, I hope we can pick some interest to the people to talk more about or engage more on mental health, and also on, especially on digitalization. I just want to leave that you don't need to be a mental health professional to do something. You don't also need to reinvent the wheel or be techie or be very advanced to do something. You just have to do something, because it's very important that we talk about mental health.
Thank you. Okay, David.
People with lived experience need to be at the center of research, program development, and service delivery.
Great, thank you. Tom.
Thank you. I just want to read this out. This is from one of our partners in Ethiopia, so I thought their voice was important to have in this as well. So they told me that well-designed innovations developed in collaboration with people with lived experience of mental health difficulties should ensure that all sectors of society can access effective mental health care when they need it. This is their hopeful headline in about 10 years' time. We're not there yet. And mental health digital innovation is not a panacea for dysfunctional or difficult broken systems, but it's an important part of emerging solutions.
Thank you, Tom. And Miranda, you'll close us out.
Thank you. I feel incredibly heartened and privileged to have listened to these conversations. I think this is exactly where mental health has to go, where we are dealing with difficult issues about what actually does a positive intervention look like and who is it right for. And we move away from general hand waving to specific targeted interventions for given communities and given individuals. And some of those will be challenging and the conversations are challenging, but that is exactly where we need to be. So thank you.
Great. Thank you so much. Thank you to our panel, and thank you for joining us.